did not get the answer at the faculty level or the coordination level, you know, this is your point of reference. Like this is like a chain of command. So he's a great in terms of responding to students. So it's just letting you know, Dr. Winston, if anything, like you're asking me and I'm not answering, go to Dr. Winston. So this is how the proper chain of command. Yes, I saw some questions. Yes.
I was going to ask, so you mentioned at the beginning that we have 206 bones. Is that in the adult body or in the child?
In adults, it's a very, like, it's bone developed, you know, developed there. You will not be asked pediatric questions as of now because we will cover pediatrics in the positioning team. Yes, as we go, it will be some details because you still might, because in your clinics, you will see the pediatrics, like some clinics have pediatric emergency department and you will be participating, right? So the only reason I will introduce some aspects of the pediatrics is mainly for clinical reasons, for you to know, because there is a difference between doing the adult chest X-ray versus pediatrics chest X-ray. Yes, you will have a pediatric, like dedicated pediatric rotation in the second year. Remember, you never can do pediatrics by yourself, even when you do the comps. Pediatrics always have to be with someone. So, but this is for clinical reasoning. I will be introducing a little parts, how to do like, okay, chest X-ray, if you're doing for adults, we're doing like this, but for pediatrics, we're doing other way, you know? Yes?
So, primary ossification occurs in the diaphysis.
Is diaphysis.
And then the secondary ossification occurs in the
Metaphysis.
metaphysis.
Again, it's not like we will go in depth to that. It's a lot of, you know, like this part that we're covering now is mainly like a general knowledge. You know, you will see, like, we want you to be informed, you know, about the stuff like when you see that X-rays, for example, in the clinic, and I'm like, oh, what that line is. The radiographer is going to be like, what? They're not teaching you in college what it is? It's a epiphyseal plate that is in pediatrics. Why it happens? Because again, the bone is not the calcified. It starts from the center, goes towards the end. That's how plate that forms, and is when it completely ossifies, like completely calcifies, so that plate is disappearing in adults. Now, with the joints, again, very brief. The only I want you to concentrate on those three names here. We have a lot of joints in our body, and we have two types of classification. Functional classification, which is mainly addresses the motion, how the joints are like moving, you know, are they movable or are they not movable? So, and we have the structural classification, like what they are made of, which tissues they're made of, primarily of. So in terms of functional classification, meaning how they functioning, how they moving, we have three types of joints. We have synarthrosis, which are immovable, completely immovable. Those joints, they connect. What is a joint? Joint is like something that connects two bones together, right? So, and again, those joints can be movable, can be not movable. Synarthrosis joints are completely immovable. They're not moving at all. Like the hint how to remember is seen to move. Synarthroidum. They're like, it's seen for them to move.
Oh, okay. Yeah, that's a good one.
Right? Like a sutures in our skull. We have sutures which are joints, but they better not move, right?
Yeah.
Yes. So, amphiarthrosis is the limited movement. They're moving by very little. Like symphysis pubis is like sometimes it just goes like it can have a limited motions, but this is like the main thing here. I want you to know the names, right? Amphiarthrosis. This is the limited motion, and diarthrosis they can do whatever they want. They freely movable joints. Is it different types of those joints how they move? but still like a shoulder, right? You know, this is, of course, the arthrosis like freely movable. This is functional classification, meaning motion. Structural classification of the joints. This is by which tissues they are connected. How those bones are connected. And you have fibrotic joints that are connected together by fibrous connective tissue. Fibrous is it's not the solid structure. It's from my English sometimes got stuck. You know, they're not the lines. Like, you understand the fibrous,
Yes.
which is like fibrotic. You know, they are held by fibrotic tissues mainly. You're gonna go just by this, like, yes, here is examples, but you know, don't overload yourself with this one. You have a cartilages that are held together by cartilages. And you have synovials. Synovial means you have a capsule that is with the synovial fluid. This is very important for the joints that are freely movable, because if they don't have that fluid, so it's going to be the friction, right? The bones will be damaged if they will not be lubricated. So that synovial fluid, so it helps them avoid that friction and allows the arthrodical movement or freely movables. So this is a type of synovial joints. Again, this is for your information. For your information. But I want you to remember those functional classification for like 3 types of joint motions. This I want you to know. We just starting, the joints is a complex structure. We just starting little by little. And let's focus on just function of the joint or motion of the joint. Make sense?
Yes.
Okay, very good. From now on, this is what we're gonna talk business. This is what we dealing with. So it's a lot of terminology we are using. Yes, it's a different language. And sometimes it's hard to remember. We will try to do our best to, you know, give you some tips how to remember stuff. So, radiography. Graphy, right? What means the graphy means?
Pictures.
It means study, right? Radiography, it means like we're using X-ray to study things. Radiograph is the image. We're using soft images now, meaning on display, on the display only, on the screen. We're not using the physical films anymore. So, and radiographic procedure. This is what we like when we're saying test, procedure, X-ray. Those are like we using that interchangeably. Means some like X-ray are done on the body. When we position every single positioning, every single radiographic procedure needs certain position. And to describe that position, because not all the X-rays are done just with putting patient like this. That's it, right? But sometimes it's like this. Sometimes it's a little like this. Sometimes it's like this. Sometimes it's like that. You know, sometimes it's like this. So step number 1, when you be reading about the procedure, is how you position the patient. And we're not putting as essay. Oh, I'm just putting patient standing, I'm making his right side turning, you know, touching the image receptor. No, we're putting that in the short terms. And all these terms starts from anatomic position. Anatomic position. What is the anatomic position? When the person stands with the palm facing forward, right? This is anatomic position. So, and that's what our starting point. Anything when you see when you look at the X-rays, that X-ray is viewed to you as patient is in anatomic position, meaning you see him from anterior, you're looking at him from here. It starts from the body planes. Critically important concept for us. We have a sagittal plane that divides our body to the right and left sides. And if that plane crosses from like in the middle, we call it mid-sagittal plane. Or in short version, MSP, mid-sagittal plane. We have coronal plane, which divides our body into front, anterior part, and back, posterior part. So, if it goes into the middle of the body, we call it mid-coronal plane, MCP. When we are describing the body position, saying the body is like placed, for example, like patient is standing, right? And to describe that there is no rotation of the body, we saying MCP is parallel to the image receptor. Does it make sense?
Yes.
So we have an MCP plane, right? It's a MCP mid-coronal. Why I'm doing like this? It helps you to remember. It's a like crown, corona, right? Like a crown is like this. Coronal plate is like this. It's not like this. So yes, if I'm describing patient is standing up with mid-coronal plane being parallel to image receptor, is like this, right? But if the patient is standing like this, then its mid-coronal plane is what? In relationship to the image receptor?
Perpendicular.
Perpendicular. But which plane of the body is parallel to image receptor in this position?
Sagittal.
Mid-sagittal. This is like they're 90 degrees to each other. If one is parallel, another is perpendicular, right? So this is what like test question. We have the body position like, for example, like this, or the side, like sideways. Sideways we call it lateral position. Test question. Which body plane is perpendicular to the image receptor if patient stands in left lateral position? And again, left lateral position, just imagine yourself. Left lateral, meaning my left side touches the image receptor. And I said which body plane is perpendicular, right? Which body plane is perpendicular? Mid-coronal. Which body plane is parallel? Sagittal. These are test questions. This is again the very little start. And it's important for us when we're doing those charts and we're describing how we position the body for the, for the chest X-ray, for the lateral chest X-ray. We're not putting mid-sagittal, we're putting MSP, perpendicular to IR image receptor. A little abbreviation already tells you a lot of information. So, the plane that is not at 90 degrees, like does not other than dividing body into left and right or anterior, posterior, are oblique planes, oblique. We also have an axial plane, horizontal one, but this is not in our X-ray dimension. In the X-ray dimensions, we have two dimensions, right? We're showing from front or from the end, like 90 degrees from each other. We cannot show the axial planes. This is three-dimensional studies, which is a CT, MRI, that's CT. So again, here's like sectional image on CT and MRI. They're showing the coronal view, they're showing the sagittal view, and they also can show the axial view, which we cannot do that in X-rays. So we also have a base plane on the skull, but we will go about that later. So, posterior versus anterior. When you're looking at the patient in anatomical position, the part that you're facing you is what? Anterior. But we never ending up with just one term. We don't like multiple terms, right? Anterior or ventral, right? Now you see my which part?
Posterior.
Posterior or
Dorsal.
dorsal. Very good. With the hands is a little tricky. And when we are, because we're not using the anterior, we're using anterior, posterior, but instead of the dorsal and ventral, we're using different names. So yes, this is anterior part, right? But we are also calling it palmar. This is posterior part, right? But we call, here's the similar, we call it dorsal, plantar and dorsal. Now we entering, I would say, very first confusing topic for the radiography student. Let's introduce two terms that are very confusing for the students. I don't have my, okay, actually next time. We have, what we never been describing now, like positioning, right? So, the two terms that we are using very often is positioning and projection. When we're talking about positioning, it applies to body position only. Body position only. Whatever I put, and we will go like more about this one, how we put placing in the lateral, in the, this position, obliques position. When you hear word position, this is the position of the body in relation to the image receptor, right? There's the image receptor, the device that captures the X-ray image. What is projection then? What is the projection? The projection applies to X-ray beam. X-ray beam. This is the pathway of the X-rays when they're leaving the X-ray tube and they are entering the patient's body. This calls projection. Now, when we describing projection, again, it's in relation of which body part the X-ray hits first, and then which body part it exits. So, if for chest X-ray, right, if the patient is facing the tube, the X-ray beam hits the anterior part first, exits posterior part first. So then we call this projection, we call it anterior posterior projection, or in short terms, AP. AP chest means what? Patient is facing the X-ray tube. Because it's anterior posterior projection. Now, if we're doing chest X-ray like this, then is what?
Posterior.
Is a posterior anterior projection. Because like it enters the posterior part and exits the anterior. Again, word projection describes the X-ray beam. And word position describes the body position. Now, when we using projection versus position, when you hear AP or PA, it always and always describes projection. It only applies to AP or PA. But if you do obliques, when you do lateral use, the rest of the position, like the rest of the procedures, we're describing that in terms of position. Why we're doing that, I don't know. That's how we do that. Again, when you see the PA chest, it means simply that the posterior part facing the X-ray tube. When you hear AP chest, it means the anterior part is facing the X-ray tube. The X-ray beam enters the anterior part first. When you, for example, hear lumbar spine AP, means what?
Lumbar spine. Anterior
Patient is
posterior.
supine. You know, and the X-ray are coming from anterior part, exiting the posterior. When you hear AP pelvis, now, when you hear PA hand, it means, now which part is the posterior one? Posterior part, anatomical position.
Oh.
Which part is posterior?
Dorsal.
Dorsal, right? And if it's a PA hand,
Dorsal, ventral.
so just position your hand for the PA hand. How are you gonna position your hand? How you position then your hand for PA hand? Like this or like this?
PA. So it's
Like
yeah.
Like this.
Yeah.
Make sense?
Yeah.
Again, for hand, we're doing PA, we're doing oblique, we're doing lateral. Only PA related to projection. The rest related to positions. For the lumbar spine, we're doing AP, we're doing obliques, we're doing lateral. Only AP relates to the projection. Obliques and lateral relates to the position. Okay? We're doing humerus AP, right? It's AP. Only AP, we're doing AP and rotational lateral. Only AP is about projection. The rest is about position. I know it's a little confusing in the beginning, but then it's easy. Only AP is about projection. The rest is position. Yes?
For something like the hand, would it be like to determine if it's right or left, or would say right hand AP or right hand
Yes,
PA?
yes. Oh, you're doing that all the time. Thank you. Again. Positioning, right? It means patient's position to image receptor. This is another abbreviation that we're gonna use. IR is image receptor, meaning like I'm pointing to the desk, but you know, like I don't have the X-ray board here, right? So, projection only relates only to AP, which is what? Anterior, posterior, right? Or PA, nothing else. No exceptions. Make sense?
Yes.
Okay, AP skull, you know it comes from here. PA skull
Posterior.
comes from here. All the obliques, this is how we then describing the position. And this is our next topic
Okay.
when we're talking about the position. Now, when be a little more confusing for us, right? So we already good for the AP and PA. Now, we also have terms that we are using, full projections, you know, but it's not official use, like official name of the view, let's put this way. It's just for us to see, you know, which view is more, like which projection is more suitable. So, but first let's start this one. Medial versus lateral. What is medial? Is any surface that are closer to the body center, right? Any surface that is away from body center, we call it lateral. How? Just again, remember which one is medial, which one is lateral. Anatomical position. For example, this side of the finger is what? Medial or lateral? This one. Yes, how to remember that? Position yourself in anatomical position. And you will see that is away, right? This is lateral. How about this one now? Here again, from anatomical position is medial. So, medial, lateral, right? Now, for the fingers, because it's like not, you know, the axial skeleton is appendicular, is a little difference, okay? If we doing X-ray of this finger, right? I can place it like this, right? And the X-ray hits this part first and exit this one, right? Or, I don't know, for any reason, if I want to break the patient's finger, I can do it like this, right? It will show me the lateral view of the finger. But then it enters this part and exits this. In terms of projection, which projection this will be that we're using lateral and medial terms?
Medial lateral.
This will be what? Medial lateral? Let's see. Yes, because this is the medial part, right?
Yes.
This one would be then what? It would be then, yes, lateral medial, because it enters the lateral side first, and medial, right? Because look, why we using this one? Because, for example, when we're doing X-rays, our main goal is to place the anatomy as closest to image receptor as possible, to avoid that distance, what we call OID, object to image distance, because the larger the distance is from image receptor, the more distortion, more magnification. We want to represent true size and shape, right? So when we're talking about the lateral fingers, so like if I have to do the second digit, right? And if I place like this, look at in the OID, look how much distance it has, right, from the image receptor. So the position is lateral, but the projection, preferable projection for this one is not lateral medial, is medial lateral. Right? But for pinky, because it's automatically close to image receptor, I can do lateral medial. Yes?
Just to elaborate, you mentioned OID, which is object image distance, because I don't know if you mentioned that already.
Object, yes, object to image distance, you know, we will get to
I was only saying.
but yes, OID is object to image distance. Proximal versus distal. Proximal again, closer,
Closer to the
right? Distal is away from the body, from the, even not the body center, from the origin. When it starts, when it ends. Here's the proximal humerus, here's the distal humerus, right? Here's the proximal phalange, here's the distal phalange. Something in the middle is intermedial. A little difference for the, again, extremities, when you see AP or PA obliques, right? What that mean tells you. If it says AP, you know that the X-ray beam enters the anterior part, right, of the extremity. If it's a PA, remember the hand, this part is the posterior.
Yes.
But when a word oblique mentions that the planes are not perpendicular or parallel, they are at certain degree, they are oblique in terms in relationship to image receptor. I know, guys, it sounds confusing. Don't worry, it will make so much sense. The beginning is always the hardest one because you are introduced, to a bunch of things. And I don't teach lab classes now, but I loved to see that transformation. You see that in lab classes. Because in lab classes, when you start your lab, first lab, and here they're giving you SID, OID, the obliques, degrees, detent, this, that, and everyone is like, how you can remember that? It's like learning to drive the car, right? You're sitting first time and you're like, oh my God, so many buttons, so many things, How about manual, We used to drive manual, I was laughing here, reading the story that they want to drive the car, they sold the car and they were not able because it was manual. And I guess you're just driving with the, 2 feet. So, but then you're learning and, it become automatic. And that transformation that I mentioned, a couple of months later, they're doing practicals, it's already, this is easy, they're manipulating the tube it's like, they are pros. That transformation always amazing to me, and I love that to see that. Here's the same way. Yes, it's a lot of new terminology, but it's a repetition. The more you go, it will make more and more sense. This is what I was describing here. All right, the lateral projections. So the lateral views can be done with the different projections, and I gave you example with the fingers. And again, when you're talking the projection, you're thinking about which way, which body part, which body side, the X-ray beam enters first. So we have lateral medial and medial lateral projections that applies only to the part that we can actually move, which are extremities. Here is for the body core, it's just a PPA. You cannot do lateral, medial, medial, lateral. But for the extremities, yes, the body parts can be turned. Now, general body position. Supine, self-explanatory, right? What it means, like when you're reading the exam, patient is supine.
On the spine.
Is on his back. Patient is prone. Is on his abdomen. It also can be applied for the hands. For example, you can see hand is pronated. Can you pronate the hand? Put your hand, pronate your hand. How are we putting that? Like this or like this? Pronating, the meaning it's on the what?
On the palm.
On anterior part, right? So this hand is pronated. How to supinate? The hand is supinated. You see? Fancy words, right? And this is actually yes, this is the simple okay, for PA chest, right? For PA hand is pronated. Trindownable position, when the head is below legs. They're using that for example, for myelograms, when they're injecting the contrast media into the spinal canal. So for the future CT exams, it shows the spinal cord better and to increase the distribution of the to reaching contrast to the the upper part of the spine, they're putting patient under a trindownable position. Fowler position is when legs are below the head. Sometimes if the patient is nauseous, for example, it's good to have him in that position. So, lateral. One more term here, as you see, recumbent. What the recumbent means?
On the side.
It's a lay down in any position. is
Side.
erect versus recumbent. Erect, it means patient is standing up, right? Upright. Erect, other word for erect is
Upright.
upright. Recumbent, it means is laying down in any position. It can be prone, it can be supine, it can be oblique, but recumbent in general means the patient is laying on the table. Lithotomy position, like this is a surgical position for different procedures. Like lithotripsy, when they are, breaking the kidney stones. Modified Sims position is similar to our sleeping position when the patient is on his side, usually it's the left side, and the right leg is in front of the left one, leaning forward. We're using that position actually. Yes, we're using actually that position for our barium enema when we are, entering the barium tip into patient's rectum. And here comes to be again confusing part. I know. Oblique position. Some x-rays like ribs, some like spine, they require oblique position, just then different from AP and different from lateral. As you see here on the pictures, some obliques can be done with the patient standing up, meaning patient being erect or upright, right? Or with the patient recumbent, meaning patient is laying on the table. Now you see, there is a different way the different obliques are represented here, right? Patient can be standing like this, or like this, or like this. So, how we describing those obliques? Again, this is we're talking about the positions. Position is always and always about the position of the body parts in relationship to image receptor. When we describing the obliques, regardless if it's erect or recumbent, those two rules applying. First, we're saying which body side touches image receptor, right or left, right? And then which body part facing closer to image receptor, posterior or anterior. Remember, everything comes from the image receptor, not how you see the patient. From the image receptor. For example, if the patient is standing like this, the way of describing that, okay, image receptor. What image receptor sees? It sees which side? Left, right? And then it sees posterior. So this oblique is what?
LPO.
Left, posterior, oblique. Or LPO, very good. Again, you're thinking about what the image receptor sees. If I'm in like this, what image receptor sees now? Right? Anterior oblique. So which means RAO. We love abbreviations. Okay, let's see here. This oblique is what?
Posterior.
We're starting from the body part, right? We have the, we have the left, we have
Left.
right. So this one is left, right? This one is
Right.
right. So which
Left.
is left part, right? Touching image receptor. And which side image receptor sees?
Posterior.
So it would be what? Left,
Left.
posterior,
Posterior.
right?
Oblique.
How about here?
Right.
Right, but which side the image receptor sees?
Anterior.
Anterior, so it's right?
Anterior.
Anterior oblique.
Oblique.
How about here? is recumbent, here is upright,
Recumbent.
here is recumbent, but the principle of naming them is the same. So this one would be what? Left, what it sees, what the image receptor sees?
Posterior.
Posterior, so it would be what?
Left posterior oblique.
oblique. How about here?
Anterior.
Right? And
Right.
again, from here,
Okay.
anterior. oblique.
Anterior. Oh, because she's
Okay,
lifted
I know
from.
it's not,
okay.
it's like nobody expects you to remember that from minute 1. Only from minute 2. Who's volunteering? Who can position yourself? Who can come here? Okay, Jonathan. Well, is it cheating? But still,
Well, you're gonna use me as a test dummy? Well,
don't appreciate you. Okay, so this position is, okay, let's start from, this position is what?
Right.
Why is the right posterior oblique? Why is not right anterior?
Because he's closer to the image
You have to
receptor.
look from image
Uh-huh.
receptor, right?
Exactly, yeah.
Image receptor feels the right side, sees the posterior
Posterior.
part, right?
Uh-huh.
Very good. Can you please position yourself in left anterior oblique? Agree that is the left anterior?
Yes.
Yes.
Again, looking from here, image receptor feels the left side,
Looks like
faces
the anterior.
the anterior.
Anterior
This is,
part.
will be your practical in the lab, by the way.
Okay.
Okay.
Can you put yourself in the left lateral? Left lateral. Why is the left lateral?
Because
Left side touch.
lateral
Yeah.
side.
Which plane is perpendicular to the image receptor right now?
The crown.
Perpendicular.
Perpendicular.
Yeah, put crown on him. Put crown on him. It will be what?
Corona.
Perpendicular, right?
Okay. So corona.
Right? And this is what, like, you have to just visualize those planes. Okay, if I'm doing AP chest, how the patient would be? Like, if this is,
chest, yeah.
everyone agree, right?
Yeah.
Yes, very good. How about for PA chest? For PA
PA.
chest, yes. Very good. How about the RAO for esophagram? RAO for esophagram.
RAO for esophagram?
Uh-huh.
Right.
I'm just not naming the procedures, that's okay.
The esophagram threw me out, sorry.
You see? Again, look for the keyword. It doesn't matter, like, when, and this
So
is the
be
thing also
esophagus.
for you. Because you will have, in the question that I just named, right? I have a distractor,
Yeah.
Okay.
right? Look for the keyword
Mhm.
and don't pay attention to distractors.
Okay.
Because esophagram in this case was a distractor. And you see how it distracted you?
Sorry.
No, but no, this is learning point. You know for sure what, like, look for the key. Did we cover the esophagram?
No.
No.
But did we cover the positions?
Yes.
So just concentrate on the position. And this is we start that from the beginning because it always, especially when you have question like this, remember, in the question like this, you have to find the key word, usually one.
Okay.
Very rare two. The rest often information, destructors. And the board loves that. Okay? So last, okay, we're doing ribs, LPO ribs.
LPO ribs?
Yes.
P.
LPO
Posterior.
ribs?
Okay,
Posterior.
what is facing?
I'm sorry.
Yes.
Ribs. Okay.
Again, you see.
Yeah,
Yeah.
Yeah.
Even for ribs.
Yeah.
For esophagram. For any other whatever procedure I'm gonna name even do not exist. The principles of the body position remains the same, okay? When you're left, if it's LPO for ribs, for esophagus, for upper GI, for whatever it is, left side, touch.
I skipped breakfast, I'll take my lunch, sorry.
Posterior part is closer. Make sense?
Yeah.
Yes.
Okay, practice with your family members on that. And
Okay.
remember. Almost done, guys. I know it's a lot. Okay, this little more again. Those oblique positions, describe. The first one standing.
Right anterior oblique.
Very good. RAO. How about laying down?
Left posterior oblique.
Left posterior oblique. Who does disagree? who still do not understand, that's okay to tell. Don't be ashamed. Let's just, come here and we will explain more. That's okay, we are family. Nothing to be ashamed, or like, don't hold it if you don't understand. Available? Okay. Yes.
So just to reiterate, the order for like AP or PA, it's the P or the A, it's depending on whatever is closest to the image receptor.
So AP or PA applies only for projections.
For projection, okay.
All these.
Okay.
If you hear AP or PA, no exceptions. It's projection only.
Thank you. Thank you.
Okay? It doesn't mean the position, because the position should be opposite. But that's why they're not like we're not even covering AP or PA position, because they are opposite of projection. But we don't want to confuse you. AP or PA will be related to projection only. Yes. Yeah,
I know. So when taking in parallel,
Slicing yourself with the crown.
like that.
And parallel is
what, like this? Yeah, but I don't know why I can't get it.
So it's like vertical and horizontal.
Yeah, pretty much.
Okay.
Perpendicular and
So if there's vertical and horizontal, why change it to perpendicular?
yeah, perpendicular.
It's like this.
I searched it.
Oh, you just.
So perpendicular is this way, yeah. And
Parallel is this way.
Yeah, parallel is like this,
This,
and then
okay.
this is perpendicular. So when she says like, oh, perpendicular, I'm gonna ask her to just go over that.
Comparing to this one, which side?
Yeah.
This side, right? So this is the medial side
So
of
the
my
perpendicular
forearm,
is
right?
then the
This one
coronal is
comparing
parallel.
to the every part has two sides. This
I'm
side,
gonna ask her to say
this side is far away. So this one is medial.
I think that's harder than this.
This is
Yes.
Honestly.
That's the one that has me like, oh,
Lost.
this is lateral. Got it?
Professor?
Yes.
We were wondering if you can get over, if you can go over the parallel one more time and
The
perpendicular, if that's okay.
Okay, let me finish,
Yes,
and
okay.
we're gonna go, because I don't want, yes, absolutely.
Okay.
I know it's also confusing.
Yeah,
We're gonna go back to the parallel, and like, but let's go finish.
Okay.
Because there is one more thing we have to talk about. I think that's it, no? Well,
Write that down.
decubitus. The word decubitus is also widely used in radiography. And what word decubitus means when you see it? Word decubitus means two things. Two things. Patient is recumbent. Patient is recumbent. And the X-ray is parallel to the floor. Because look, in usual situations, right? When when X-ray beam is parallel to the floor, comes like this way, right? Parallel to the floor, right? Is usually patient is standing. But when patient is recumbent, right, on the page, usually the X-ray beams from the above, right? But in this case, patient is recumbent, so it might be in any position, but the X-ray beam is parallel to the floor. Those two factors, what we like, that term for these two factors is decubitus, and sometimes we need them. Sometimes patient cannot stand, but we still need to see, especially in the trauma views, we have to show minimum two images that are 90 degrees from each other. But what if the patient only can lay on the bed and that's it, we cannot even turn the patient? Then we are turning, like doing, like working around the patient. We're doing one AP, right? For example, to see the spine, right, cervical spine, the trauma, very common trauma. We're doing like this, but how we doing like this, like lateral view, if the patient cannot be moved. So then patient is still laying down, but we turning the machine 90 degrees. Okay, again, decubitus means patient is recumbent. but the X-rays are parallel to the floor. Now you see, when this is like I said, recumbent, right? But patient can be in different positions, and this is how we describing particular decubitus. For example, here you see patient is in the lateral, right? On which side is laying down? On the right side. So this is why, no, this is not
No,
on the
left.
side.
Left.
Yes.
The left side.
This is on the left side, right? So this is why this is left lateral decubitus, meaning patient is laying down on its left side. But the X-ray are coming from the side, like parallel to the floor, right? It's not from above.
Question.
Yes.
So the image receptor is
Image, the receptor is like on other side of this one is like, yes.
it'll be behind, but why would they left?
Because the position describes like on which side he's laying.
Okay.
Is laying down. This is the position. Then we can add projections to it, right? This one would be which projection? AB projection, because you're completely right. Sometimes it can be back for the patient. The position is applies to the body position. The patient is laying on his left side. Position is left lateral. Projection is AB. Because patient can be on other side, or head can be this way, depending on the situation of the patient, how like we happen. So here is right lateral decubitus, but the projection is PA. Yes, to the oblique position, not when it talks to the body, usually no. It's only for extremities. Here's like, we don't do decubitus oblique. For the decubitus is a special use that usually the patient is either on the side or like the next use. LPO, yeah, projection is would be like AP, yes, but it's like technically, but we're not describing that for the body parts. Like, yes, it should be for LPO, the projection would be AP. But when we're talking AP, like, do not confuse yourselves, like in our terms, professional terms. AP means is just simple AP. If you want to go deeper on that one, yes, like technically, yes, the posterior oblique are like AP projection. Yes.
When it comes to the position that lateral decubitus, does it always have to be with an AP projection or can it be a PA projection?
It can be PA, depends on the patient's condition, patient's situations. Maybe it's a trauma patient, and the patient comes with the side, he can be turned, like it depends. No, not at all. So almost done. Now, that was regarding the lateral decubitus, but sometimes the patient is on the spine, on the back, or on the of the abdomen. So then we calling it what? If it's on the back, remember, like, yeah, patient is supine, but we don't like that. It's too simple. We want to be fancy. That's why we're gonna call it dorsal decubitus. Why? Because patient is laying on his dorsal part versus ventral on his anterior part, right? So, did they do that again? Let me ask you something. Guys, what time your class starts? 10? Because mine just answered 10. Oh, that does, okay. Don't look, I was like. Well, in the situations we were describing previously, always our X-ray was perpendicular to image receptor, coming at the right angle, right? Even from above, from the standing, in the decubitus, but it is also perpendicular to image receptor. But some anatomy requires the angle, requires the angle of the central ray. Why? Look, when we're doing study of the certain bones that anatomically within our body are angled, like a sacrum, Our sacrum is not parallel to the image receptor. Our sacrum is angled. But we always want to show the true size and shape. We always try to bring our x-rays be perpendicular to the anatomy of the interest. For example, if it's a spine, usually spine is parallel to image receptor, like with some, yes, curvatures, but not as much. So we're using perpendicular image receptors, or perpendicular x-ray beam. But when it comes to the sacrum, to the coccyx, to the other parts that are angled, so in order to be perpendicular to that anatomy, we have to angle the central ray. And there's two ways of angle it. We angle either towards feet or towards patient's head. If the central ray is angled towards patient's feet, we call that caudate angulation. 15-degree caudate angulation, meaning we're angling the X-ray beam towards the patient's feet. If we're angling the X-ray towards the patient's head, this describes cephalic angulation or cephalic. Here's something that you should, review. We went over the major parts, but this is your reading assignment. The textbook explains those relationship terms very clearly. So this is a part of your homework. And this one, this one is okay. We can do that next class. So we finished what we wanted to finish. Now, before answering parallel or perpendicular, I want to show you guys the homework. So for the homework, I simply want you to print out the document. And you see, and remember, homeworks, yes, I will be grading them and reading, but this is your study guides. When you're writing them to yourself, that's your study guide. This would be like of the terms that you're gonna read, and you're gonna put it here. Okay, this is, I can see that you read the part, and you did that. Now, another homework. It will be the chart, but this for later on, when we're gonna be covering chest and abdomen. And this is what I was, like when I was telling you charts, this is what I was referring to. PA chest, what we're putting, patient position, part position, SID, centering point, essential information. I even uploaded the example for you. Where is that? Here. Oh, it's not published. I'm gonna publish right now. This is like just example, what to put, use the abbreviation. Although I had put here as like mid-sagittal plane, but if you put MCP, and instead of perpendicular, right, even that, like it would be what? MCP, perpendicular to image receptor, or MSP, parallel, right? You know the sign of perpendicular parallel. You can do the short version of that. So this is the charts that I will require you to do for every procedure. Okay, this is not a lot to do. Although yes, it's like 2 homeworks, but they're not the large homeworks. Okay, so let me publish that, and I'm gonna update the due dates for
Homework
Oh
2 is after we study
Oh,
the
okay,
chest
okay.
and stuff, so that should be after that.
Okay, I published. Yes. No. All the homework I will be physically collecting. I want like physically. Yes, you have to print out. Yes, you have to write. You have